So we're back with Dr. Van for our second episode on prostate cancer. We talked about initially the shock of having an elevated PSA or prostate-specific antigen, whether you observe this, whether you get another diagnostic test or biopsy. But so now I've come back into the office and we've decided to go with a biopsy because the MRI was abnormal. So you've biopsied it and it comes back that indeed I do have prostate cancer. I'm relatively young. I'm below 65. We've agreed to that. And I have, say, 35 years of good living is my hope. While this is not the most malignant type of cancer, it's certainly not the most benign. What do you... Walk me through how you tell me as a patient my options, and I'm telling you as a patient, hey, I have this cancer, I'm in good shape, and I have 30 plus years of good living. I want to be cancer free, but I still want to be able to, urinate on myself, not wear a diaper, and I still want to have fun in the bedroom. I mean, I'm sure that's what everybody asks you, right?
Yep, that's correct. And probably in that order, like you said. They, first and foremost, people want to be cancer free. It's on the other two, it's hit or miss, depends on the guy. so anyway, but so I would tell you first. We would talk about what type of cancer you have. I'd say, I'd tell you that the biopsies did come back positive, and then we would talk about what's the grade, how much is involved, volume of cancer that's there. Based on that, we can plug you into in those things, we can actually put it into a nomogram and find out what your risk of metastatic disease is, what your risk of a positive margin with surgery is, what your 5-10-year recurrence rates are, and give you some more information about your particular prostate cancer, and then decide on how we're going to treat it.
All right, the risk is too high for me to bear. I can tell you that right now.
Right.
Okay, so.
Well, I would tell you, if you came back with the Gleason 6, like we talked about in the last podcast, I'd really try to push you, unless it was high volume. Okay, so sometimes you have men who have...
High volume, explain that to everyone.
I'm going to get to it. So sometimes you have men that may have 1 or 2 biopsies that show a Gleason 6 cancer. But let's just say you got a guy...
Gleason 6, everybody understands, that's pretty malignant.
No, it's low risk. Gleason 6. So let me explain the Gleason score real quick.
6 seems like a high number to me.
I know it is. I know, but the way that's a podcast of itself to tell you about how the pathologist comes up with that. So
I'd want a 2, I think.
So right. Yeah. So a 6, even though it sounds number, is a 2-number combination where they use the most common pattern of cancer that they find, and with Gleason 6, it's all pattern 3, so they combine it 3 plus 3. Which comes to a 6. On the other hand, there are those that have maybe pattern 4, pattern 5, which are much higher risk or more aggressive prostate cancers. So you can have a patient with 4, but then they also have a little bit of 3. You have a patient with 4 that has some 5, and so that's a 9. So the higher that number gets to 10, the more likely or the more aggressive the cancer is.
Sure.
Okay. So really, for all practical purposes, anything that is 7 or higher, we're typically going to recommend treatment. Not everyone, but we're going to recommend some form of treatment for them. When it's 6, okay, and you really don't see the ones lower than that anymore, but if it's 6, we typically are going to recommend surveillance, if at all possible, but sometimes you will have that guy who has high volume Gleason 6, meaning that he has a lot of cancer in his prostate, but it's all that low risk type of cancer. So in that case, depending on age, and typically we would probably err more on the side, you would use your germline tests in this, trying to figure out, is this guy more likely, but more than likely we're going to recommend some form of treatment. For some reason, his cancer is growing.
So let's assume this is growing. It was 1.8 2 years ago, a year ago, now it's 7.8. So what do I recommend?
Right.
How do you it's contained within the prostate, and
well,
I want it out.
Sure, the MRI is going to give you a good idea of whether it's contained to the prostate or not. It's also going to give you a free look at lymph nodes to see if you can see anything that lights up there. Most of the time, most people we see, unless their PSA is out the roof, like 50 or above, more than likely they're going to have localized prostate cancer.
So when you say lymph nodes light up, so everyone knows, that
Anymore.
means it is spread, while it doesn't appear to have spread beyond the capsule of the prostate, there's abnormal lymph nodes, which means the cancer could have spread through other channels, not through direct extension.
That's correct.
Which means it could be metastatic or spread, is that correct?
That's correct.
Sure.
That's correct. And then that just factors into, the staging and what stage of the cancer it is, and then and it may also affect what we offer as treatment.
Sure.
So, so if you came to me, and let's just say, I'm going to give you a common scenario, you've got Gleason 7, 4+3 cancer in 2 cores, and it looks confined to the prostate, because that's typically, somewhere around that we're going to see an organ-confined cancer. So your options would be for a localized prostate cancer like this, it would either be surgery or radiation therapy. So, we're going to talk about robotics, so we'll kind of focus on that. And for a young guy, I'm typically going to recommend surgery more often. Now, I do tell them about radiation and then let them make their own decision. But more than, if it's a more aggressive cancer, we're going to tend to recommend surgery is the best option.
And radiation, so everyone understands, what you're doing is essentially a version of X-ray type therapy that shrinks the tumor by choking off blood supply.
Right.
Okay, and tell us about some of the side effects that would be associated with radiation to the prostate area.
Right. Well, the way and also the way I kind of explain it to patients is that what cancer is basically uncontrolled cell growth. So
Sure.
Radiation will damage the DNA so that the cells can't replicate, but you're radiating normal tissue and you're radiating cancer tissue, so you're radiating both. So both tissues get damaged. The normal tissue that's not cancerous typically can repair itself. The cancer can't. So that's kind of typically how this helps them understand what it's trying to do. So that being said, when you radiate the prostate, you're going to radiate part of the rectum, you're going to radiate part of the bladder. Now, it's a lot better than it was in 1972, meaning you don't have to go as wide on a field. We're definitely more focal with our treatment, but you're still going to radiate those organs. So if you have a guy, which oftentimes I do have guys that come in with lower urinary tract symptoms just due to BPH, meaning the frequent urination, urgency getting up at night, those symptoms are probably going to get worse with radiation, number one. Number two, if they have, sometimes there'll be radiation cystitis or proctitis where you get blood in the stool, blood in the urine, painful bowel movements, bloody bowel movements. It happens in about 20% of patients.
20%? That's
yeah.
1 in 5 get a painful bloody bowel movement?
Right.
Jeez.
So it's not, something to be, it's something to really consider, as far as, that. So, I think it, and we tend to deal with it more so, no disrespect to radiation oncologists, but we tend to deal with those problems. And so it can be kind of miserable for the patient, if that happens to you.
Sure.
So,
Sounds like it'd be miserable.
Right.
Just thinking about it.
So, on the other hand, the advantage though is there's very little there's less risk of incontinence with radiation therapy. For some guys,
You mean urinating on yourself uncontrollably, right?
Right. So that may appeal to some men more so that they're really worried about that, or they just don't want to have an operation.
I don't want either.
Erectile dysfunction, I know, nobody really does. Erectile dysfunction really is about the same, whether surgery or radiation, because you're still radiating the nerves.
We'll concentrate on that in a bit. So radiation would shrink the tumor, but you'd have to do a lot of surveillance because the tumor is still there, potentially it has died off, so serial MRIs and blood tests and those sorts of things.
Right.
So that's one option. We talked about some of the side effects. And let's talk about prostate surgery's gotten a lot better. You're a very good prostate surgeon. Lots of patients and friends that you've operated on, and excellent outcomes, everyone, by the way. If you want to see Dr. Van, a little plug for him. But it's really true. So tell me, what is the most advanced surgery that we do today? The robotics, everyone sees it on the internet. Tell us a little bit about that and why that's so advantageous. Right.
Well, I do a lot of robotic surgery, and the way I explain it to a patient is that it's laparoscopic surgery. It's just a little fancier because the robot gives us a lot more flexibility in terms of wrist manipulation or flexibility of the instruments and how they work, so that we can do a fine operation or make little small movements within a very tight spot. And that's essentially, when you're doing prostate cancer surgery, is the prostate's like a bowl, it's like the bottom of the sink, and the prostate's sitting right in the drain hole, like it's basically at the bottom of the sink. So you're trying to operate within this bowl, and so it gets a little tricky. And then on the other hand, you're also working with the organs that, your bladder and the sphincter muscle, those things that can lead to urine leakage and erectile dysfunction, which can really affect a man's lifestyle. So it's a very technically challenging operation. And
because I want to explain, everybody here, we hear these famous terms, laparoscopic. So essentially what it is, there are small holes made where there's long lighted tubes and instruments, and through these small 1 centimeter, quarter inch, half inch holes is where you're putting these instruments, putting these lighted tubes, and then you're controlling these instruments in ways that your joints can't articulate as a human.
That's correct.
And then you're carefully dissecting away those structures to salvage those nerves so that the sphincter, so you don't become incontinent of urine, you don't lose the ability to have an erection. And the best case scenario is all of the tumors removed and you're continent, meaning you hold your urine and don't have any problem with an erection. What's the risk of erectile dysfunction with robotic surgery and urinary incontinence with robotic surgery, both short term and say long term, a year after once you heal?
Well, it's about a 5 to 10% risk of incontinence. The short term, most men are going to leak some. They're going to leak some. And it takes anywhere from a month, sometimes 2 or 3 months for that to resolve. And there's exercises that we'll teach you, that we teach patients to minimize that. But that's the typical post-op course. So about 3 months it's going to last, and then
the incontinence.
Right. Erectile dysfunction, there's still about a 40% chance that you could get ED.
Did you say 40?
40.
Not 40?
40. Now, that doesn't mean that you're not going to be able to have sex again. Okay, we can do things that you can get it, but I'm letting you know, a spontaneous erection, there's about a 30-40% chance that you're going to have erectile dysfunction.
Did medicines help with that?
They do.
Okay.
Pills, and then there's half of those men we can salvage with a pill. Okay. I'm just giving you the realistic numbers on it, and
I understand.
But yeah, it's a big risk.
It sounds like it. So now we've gotten through surgery. Our next podcast, we're going to talk about what to expect after surgery. Okay? So we'll go through that shortly. Thank you as always.
All right.
Thank you.